rehabilitation department. Uh, so first and foremost, what is a physiatrist? Or what is physiatry? What do physiatrists do? Is it physical therapy? Is it psychiatry? A lot of people end up asking this question when they see me for the first time because they're not familiar with a physiatrist. A physiatrist is a physician and is commonly interchanged with a physical medicine and rehabilitation physician. And it's physicians who specialize in treating medical conditions that can affect the brain, the spinal cord, your nerves, your bones, your muscles, your joints, your tendons, your ligaments, basically your body, your musculoskeletal and nervous system. And the big focus is on function. Like, what can we do to get you back to doing things that you need to do, the things that you want to do with diminished pain? What adaptations can we make? What devices can we use to get you back to doing what you need to do and want to do? So we focus on specifically on non-surgical options. We work very much closely with neurology and orthopedics to find non-surgical options for patients that don't need surgery, don't want surgery, or otherwise can't get surgery for one reason or another. They're not good candidates for surgery. So physiatrists can specialize further into spinal cord injury, brain injury, pain medicine, sports medicine, such as myself, neuromuscular medicine, pediatric physiatry, and hospice or palliative care. So as I mentioned, the focus is to work with a team and closely with, our neurologists, our orthopedic surgeons, our physical therapists, occupational therapists, speech therapists, our athletic trainers. It's work in a team to get a patient back to function, back to form, and back to activity. So specifically for today, we're reviewing what is arthritis, and arthritis is derived from the Greek term for a disease of the whole joint, the disease of the bone. It's a disease of the joint itself, the articulation, or basically where the bones kind of connect. Um, so it can be either inflammatory or non-inflammatory. The one that we're all familiar with, osteoarthritis, is non-inflammatory. And, that might confuse a lot of people because they were like, you might say, I have osteoarthritis and it's very inflamed today, or it's been inflamed for a while. How can you say it's non-inflammatory? And what it really comes down to is like, what's driving the arthritis? Is it the disease of the joint that's then causing the inflammation, or is it the inflammation that's causing the arthritis? So when it's the disease of the joint, when it's the arthritis that's causing the inflammation, that's what we call osteoarthritis essentially. And when it's inflammation that might be causing earlier onset arthritis, that's what we call a secondary arthritis. So arthritis can be primary or secondary. So secondary arthritis we could find as a result of that inflammation. It could be from gout, from rheumatoid arthritis, from lupus. It could be from a prior injury that you might have had that leads to earlier onset arthritis, like an ACL injury or tear within the joint itself. It could be caused by a lot of different things. And that's what's driving the arthritis. So, unfortunately, arthritis is way too common both in the world and in the United States. This is numbers from 2022, but about 3.3 to 3.6% of the global population suffer with arthritis, and that amounts to about 528 million people worldwide. It's actually can cause moderate to severe disability in about 43 million people, and it's the leading cause of disability in the United States. In about 2019 to 2020, about 1 in 5 US adults, almost about 20%, or 53.2 million, had a diagnosis of arthritis at some point in their life. And it's established that greater than 100 million might have it by the year of 2050. And in about 2011, about 100, I'm sorry, in 2011, approximately 1 million people were hospitalized for osteoarthritis, and it's led to about 15 billion in annual costs for patients. It's the second most expensive disease in the United States itself. It's stated that some of these numbers might be a little bit off as well. It might not be completely correct, especially since COVID. There was a lot of people that were in lockdowns. that were staying at home, decreased physical activities, the stress of COVID itself, that it might have led to even increased numbers that have been happening as well. So, arthritis itself can have several risk factors, and there are risk factors that are modifiable and non modifiable. Modifiable risk factors are essentially things that we cannot change, we can't control. So, age is one of the risk factors for arthritis. It's probably one of the most common ones. And as we tend to age and get older, there's an increased risk of arthritis, and about 88.3% of of patients in the United States with arthritis are above the age of 45 years old. Women have a higher chance of getting osteoarthritis than male do, and sometimes that's due to anatomical factors as well too, in regards to the shape of the hips. Some patients are also born with certain angles or certain formations how their knees appear, such as that knock knee appearance, which can also lead into it. Patients that might suffer from muscle weakness, whether it be from a stroke or a muscle disease or myopathy, that could cause it. And certain races can also have a higher risk of arthritis. It's seen, studies have shown that there's a lower risk in Asian populations and a higher risk in non-Hispanic Caucasian populations. Now, modifiable risk factors are things that we can actually change. A higher BMI is associated with an increased risk of arthritis. As we'll talk about later, weight loss is associated with helping decrease that risk as well too. A history of prior joint trauma, such as an ACL tear, a meniscal tear, which can cause bleeding into the joint, or another injury, that can increase your risk for arthritis. Certain occupations, especially occupations that require repetitive heavy load or squatting or even heavy vibration, jackhammering, those kinds of things, can also have an increased risk of arthritis. There's also certain, it could be a part of metabolic syndrome, patients that might have high blood pressure, high cholesterol, and diabetes. We've seen an increased chance of having arthritis, as well as inflammatory um, things that can be pro inflammatory, such as smoking. Vitamin D deficiency, low bone density, or osteoporosis. And there's also increased risk associated with depression, lower education levels, and lower physical activity. Um, So a lot of patients will ask me this: I have arthritis, I have this diagnosis of arthritis. Will my arthritis get worse? And if we're strictly talking about the imaging of arthritis, which we're going to talk about soon in the lecture as well, the image appearance of arthritis may not necessarily get any better. It doesn't necessarily mean that it will get worse, but it might not necessarily go away. It's there, it's wear and tear that might be on the bone. Some factors that are associated with a higher risk for progression, not necessarily for image findings, but for the pain associated with arthritis, is when you start off with a more advanced level of arthritis, or a higher degree or severity of arthritis is associated with it getting worse. When you have a higher degree of pain at baseline levels, or a lower degree of function, meaning you're not able to do as much because you're having much more pain, there's a higher risk of that progressing. For knee arthritis, when it's present in both knees as opposed to just one knee, there's a higher chance of arthritis as well. And weight can also play into it as well. A history of prior knee surgery, like whether it be what we had discussed, an ACL tear, whether repaired or not, can increase your risk, and those malalignment, those malpositions of those knees. And then depression in general, poorer general health can be associated with arthritis advancing or progressing. Now, how does it happen? How does arthritis necessarily happen? There's a lot of risk factors, and most commonly with osteoarthritis or primary osteoarthritis, it's from mechanical stress, essentially wear and tear that happens in the joint. What I most commonly compare it to is just like tires on a car. You're using those tires, you're living your life, you're doing activities. Arthritis might happen into the joint, and it'll happen over time with wear and tear. That then causes that inflammation that happens in the joint, and that leads the joint kind of goes haywire, because it's like, well, what do we do? What can we do about this? What can we do to fix this? And it'll tend to put on more bone in that area. So first, it just starts off with a little disruption, maybe some loss of the cartilage or the lining of the joint. I like to commonly refer to it as that overcoat in a paint, like that top layer. There's some wear in that cartilage that happens before it penetrates the deeper levels. There's a narrowing then of that joint space, and when that body goes into like overdrive mode, trying to fix the problem, it'll sometimes create more bone or spurs. That's why you might notice for if you've ever known someone or seen someone with arthritis of their hands, it's like a little bulked up. But those knuckles look a little bit bigger. That's what we call osteophytes or spurs that are happening. Your knee might look bigger from osteoarthritis that's happening, and then eventually it could lead to further joint space narrowing, swelling that could happen, and then that term that everyone's always afraid of, that bone on bone arthritis. That's the big one that a lot of patients are afraid with. Do I have bone on bone arthritis? Is it that bad? Um, Now, where this matters most for us is your arthritis symptomatic? And the symptoms of arthritis can vary greatly. An overwhelming majority of patients that have arthritis never even know. It's asymptomatic. You may have arthritis in a knee and a hip and a shoulder, and if it might not be bothering you, and if it isn't bothering you, there's nothing that you necessarily need to do. If it isn't broke, you don't fix it, right? Now, when patients do have symptomatic arthritis, they can complain about pain. It's usually this aching, dull, throbbing pain that might be worse at the end of the day, and it gets better with rest. Oftentimes, patients will say they have this stiffness or crepitus. They could hear their knee, like, or their hip or their shoulder kind of ratcheting. They feel that clicking. The stiffness and the pain, they'll say, gets them first thing in the morning. It might last for usually less than 30 minutes, but as they warm up, it gets a little bit better as they start to move. So you're sitting down, it creeps in, you get up, start moving. It's there in the beginning, but then it starts to wear off as well too. And that's usually when it's like much more severe or later stage, it could hurt at all times. So you could get that bony enlargement, that larger appearance of the joints itself that could happen. And sometimes it could even lead to instability, that feeling that you're buckling or giving out at certain parts of the joint. Um, Sometimes if it's really severe, and there's a lot of spurring that could happen, it might actually cause a limitation in how much you're able to move your joint. You're not able to move that shoulder all the way up or bend that knee all the way. And because of that, that then can, that inactivity or lack of moving can lead to weakness. This could all lead to a loss of mobility, function, doing the things that you need to do and want to do, or even sleep. So arthritis can essentially affect any joint of the body. It's a disease of the joint, so it can happen anywhere essentially. But we see that it commonly affects the larger joints much more commonly. Probably the most common is actually in the knee. About 30% of the population above the age of 45 it's happening in the knees, and it's the largest cause of physical disability in the world. Um, that's what usually we'll see, that the knees look bigger. Patients will say, you know what, when I walk, I feel this pain in my knee. I could feel that clicking, that cracking that happens. I can't bend my knee all the way. I have a knee swelling that's coming and going, or just there all the time. I have that knee stiffness. Um, Hip is the second most common area. Patients will often complain about pain that's in the groin. Usually it's in the groin. It can wrap around to the side of the hip or sometimes even into the buttock. And sometimes they'll even turn their foot in a little bit because rotating that hip out can be a little painful. So they'll like to turn it in just a tad bit so as to not, cause too much grinding of that bone. Um, Followed by the hands, most commonly actually happening at the base of the thumb. That's usually where we see it when it comes to the hand. And as you could see, it could sometimes lead to that oversized appearance of those knuckles. We call these Herbendens nodes and Bouchard's nodes. But at the base of the thumb, at the CMC joint, that's usually where we see it most commonly in the hands. And then it could happen in the shoulders. Usually patients will say that they're not able to lift their arm all the way up. They're not able to move their shoulder all the way back, putting on jackets. And very commonly as well, it could happen in the spine. It could happen in your back. That you could have arthritis of set joints in the back or stenosis, and sometimes if it's severe enough, it could actually even just push on nerves and cause even like sciatic type pain, pain that's shooting all the way down your legs. So how do we diagnose arthritis? Usually the first thing that we'll typically get, imaging wise, would be an X-ray. Arthritis itself is a clinical diagnosis. It's that pain that's worse with activity, that morning stiffness, especially in a patient that might be above the age of 45. There's no blood work for osteoarthritis. We might do blood work when it comes to the inflammatory arthritis, that rheumatoid arthritis, even checking that joint inflammation, sampling that fluid to check for gout. But for osteoarthritis, there's no blood work that typically shows it. Um, when we're getting these X-rays of the specific areas for arthritis, we can see that narrowing of the joint space. We could see extra bone or spurs that are there. We could see there's not as much space in there, and that bone is what we call, it looks remodeled. So typically we could see it, especially pretty quickly on an X-ray. A CAT scan is another image. It's much more sensitive for bone, but we don't always need a CAT scan unless we're suspicious of sometimes even like fractures. An MRI can be more sensitive. It can detect arthritis a little bit earlier and much better than an X-ray can. We don't need it that often. Usually, we're only ordering an MRI to look for arthritis. If our X-rays looking normal, and then we get the MRI, and we could see a little bit more of that cartilage, that lining a little bit better. On our ultrasound, we could also see that fluid that's there. We could see that spurs that happen. And as I mentioned, sometimes we test synovial fluid, or when your knee or joint is inflamed, we're able to test that to check for the gout or other type of rheumatoid arthritis. Typically, when we order blood work is when we're suspecting that inflammatory arthritis. Usually, I find that when patients are complaining about pain that's in multiple joints, not just in one joint, maybe it's not just in both knees, it's in both knees, it's in the hips, it's in the hands, it's in the shoulders. That's when I'll have a suspicion, hey, is there something else that could be going on that's causing the arthritis that's happening at multiple locations? Is there something inflammatory that's driving all this? And that's what will kind of help guide me in looking into further blood work to see if there could be something else that's causing it in multiple areas. So, as I mentioned, how we grade arthritis depends on our image, and this is how severe it can be. You could see at the beginning all the way to the left of the screen. That's what we call zero. The X-ray looks pretty good. They might have symptoms of it, that they're describing to you. You might say, I have the pain, I have the stiffness, but your imaging looks pretty good. You might even have that clicking noise, but imaging overall looks okay, and that could range all the way to grade 4, where the joint space, the space in between the bones are much more narrowed. There are spurs that are happening. Sometimes you could even get what we call loose bodies or extra pieces of bone that are floating in between the joint that could sometimes catch and make it a little bit harder for you to move that joint. Now, this is very important to realize that just because you have an image finding of arthritis, that does not mean that you will have pain because of the arthritis. So just because you have a finding of arthritis, you had an X-ray, you had some kind of imaging that showed that you have arthritis, just because it's there doesn't mean that you have to be symptomatic of it. Doesn't mean that you have to have pain. Actually, more often than none, patients don't have pain, even though they have arthritis. This is actually some numbers from a study that was done. Um, about over 3,000 people that had absolutely no pain. They just did some imaging of the back, and then at different ages, 20, 30, 40, 50, 60, all the way up to 80. And on patients that had no pain, you could see that even at the age of 20, there was, up to 30% of people that had degeneration of the disc. They had degeneration of the facets, all the way up ranging to 80, where it's about 96% of people or 80% of people had signs of arthritis and wear and tear on their imaging with absolutely no pain. The image does not correlate or does not relate to how severe your pain is. It shows me how severe the arthritis is, but just because I have patients that have severe quote unquote bone on bone knee arthritis and have absolutely no pain. We might have just grabbed an image just to look around, and it's like, okay, you know what? There's some decent arthritis. Does it bother you? No? Okay, nothing we need to do. And then I could equally have a patient that has very mild degenerative changes or arthritic changes on their, on their finding, and they could have much more severe pain. The image doesn't necessarily correlate with how severe the pain is or how much it's affecting you. There's no uh, imaging doesn't really show us pain. There's no image that actually shows us pain. Only you, as a patient, can tell us how the symptoms are, how it's affecting you, how it's affecting the things that you need to do and want to do. The image helps us guide our interventions. Is the main thing. If we need to progress to do, other interventions, that we're actually going to talk about, it'll help guide for where we need to specifically target. Um, so when it comes to what I call flares, like flares of arthritis, a flare of pain, not a pain that you might have had for a long period, but you were just living, doing your activities, and you tweaked wrong, you slept wrong, you pulled something, and now all of a sudden you have a flare of pain. Usually, the immediate treatment that I recommend, that's where you typically recommended, is relative rest, and you'll see relative is in quotes there. And that's relative rest is very important because bed rest is actually almost the worst thing that you could do. Symptomatic rest is what you want to do. You do the things that don't hurt. You don't want to do the things that hurt. So you want to try to gauge and move your body as much as you can, as light as you can. Might be not too crazy, might be a little, might be some stretches for some patients if they're having a flare of back pain or whatever it is. But whatever you can do lightly, you advance as tolerated because that will get you back much sooner than if you just did strict bed rest. Usually, the only times I'm recommending strict bed rest um, is typically when there's a fracture that's involved. But otherwise, rarely do I recommend bed rest. So, gentle exercise, as much as you're able to tolerate, is always key. Sometimes we make use of braces to help, guard the pain while you're still able to function, do your activities, go to work, go to school, return to your sport, whatever it is. Just bracing to help, minimize pain in that area, and then avoiding strenuous activity. Nothing too crazy, like skydiving or jumping or like, nothing that's very dynamic or, that involves a lot of impact. So only low impact activities, usually for the flares in the beginning. So when it comes to our interventions, especially operating from a non-surgical standpoint, there's a lot of things that we could do to intervene for pain that is due to arthritis. And I'm a very fervent believer in that exercise is medicine. If you see me, as a patient, the first thing that what I'll tell at the end is if you leave the door with one thing, the one thing that you should do is some form of exercise. And that could be either with physical therapy or on your own if you feel comfortable. Some patients, when they're in severe pain, they need that extra help from a physical therapist, occupational therapist, hand therapist to guide them through exercises, to guide them through pain, help them break down tissue, show them the right things that they need to do. But the exercises are lifelong, and that's with or without pain, is what I like to stress. Those are lifelong. That's for you, with or without pain, your friends, your partners, your family members. Exercise is medicine. Exercise, motion is lotion. Moving now is what will keep you moving in the future. So exercises can be both aerobic, cardiac exercises and resistance-based exercises. You know, Focusing on reduction of that weight, we know that, increased weight is related to an increased risk of arthritis and the risk for progression of that pain. So decreasing that weight is key. Actually, 1 pound off a scale can actually be 3 to 6 pounds off your knees, actually. So 10 pounds off a scale actually translates to 30 to 60 pounds off your knees. A lot of people get bogged down about this, especially in this day and age, about the scale. But what I try to really stress is don't worry about the scale so much. Worry about and focus more about strengthening. Once you solidify a good strengthening program and a good nutrition program, once you put your body at that caloric deficit because you're exercising, because you're doing all those things, the weight will slowly and gradually come down. And actually, eventually, as you build more muscle, as you're decreasing the pressure across that joint, sometimes there might even be a plateau in your weight loss and weight gain because you're building that dense muscle, which is good. Balance training, especially for lower extremity arthritis, is great because we're not putting abnormal forces on our ankles, on our knees, on our hips. And when it comes to cardiac exercise, we're not looking for heavy impact exercises, nothing too like jolting, especially in the beginning. Usually in the beginning, we're starting more lower impact. That could be walking, gardening, stationary bike, and swimming. I'm sorry, but unfortunately, work does not count as exercise, even if you are typically living, working in a pretty active job. We need something that keeps the heart rate up. So moderate intensity exercise, about 150 minutes a week translates to maybe 30 minutes for 5 days a week. So something to be more active, things that are out of our way. If you're someone that's used to using the elevator, for work, getting to and from your floor, maybe taking the stairs instead, that's a form of exercise, doing things that are outside our routine, daily, activities. Now, when it comes to physical therapy, we're trying to strengthen the muscles around the joint. For some patients with severe pain, whether especially in their lower extremities, their hips, their knees, their ankles, that can be very hard. Like, how can I exercise? How can I do activities when the pain is just so much? I can't move. Aqua therapy is a pretty good solution for that because what aqua therapy actually does is reduces that weight bearing. You're moving gravity from the equation. You're in that wall, that water, so there's that buoyancy that's keeping you up. So you could do those exercises, and at the same time, there's resistance. That viscosity of the water is that resistance is there, so you could help strengthen the muscle. So aquatherapy has been shown to improve pain, stiffness, function, and muscle strength, and it's a pretty good tool for patients that might have that difficulty, especially on land. Bracing we talked about. Typically, there are some braces, especially for the mediums and larger size joints. The hip, not as much, but the knees. For some patients that might have the malposition where they might have like the knock knees or the bow-legged knees, there are some braces that are on the market that could decrease the pressure that's in one direction by pulling it to the other direction. Um, for patients that have knee arthritis, sometimes they might have. Like to take a look at the feet just to make sure that, like some like flat feet might not be contributing to it. So, and if that's the case, a shoe orthotic. And then, especially during flares or severe or chronic arthritis, using a cane or using a walker can help decrease the force that's across your knee or your hip to help decrease pain and make you more functional. When it comes to medications, we like to use a variety of medications. Acetaminophen, also known as Tylenol, is usually a pretty nice, first grab because it has minimal side effects. Obviously, you want to be careful for patients that might have liver issues. We make use of anti-inflammatory medications such as like, Advil, Aleve, ibuprofen, those types of medications, especially for flares of pain. Sometimes, especially when nerves are involved, especially in that spinal arthritis or stenosis or facet arthropathy that can happen. We like to make use of nerve medications that are specifically targeting nerve pain as a result of arthritis. Duloxetine is another medication that can also affect the nerves. A lot of people know it commonly because it can be also used for depression, but we found that it could help with chronic low back pain or chronic knee arthritis. So sometimes we'll try to make use of that. And then there are topical agents or gels, there are diclofenac gels, the lidocaine patches, the menthol creams, the The biofreeze is the capsaicins, the CBD creams that could help out with the pain. And then, not often, but rarely, for patients that aren't approved, and it's usually in short instances, some patients need to go on more of those narcotic medications. Now, any of these medications, you want to make sure that you're under the guidance, of your, medical provider, just to make sure that it's the right choice for you. Now, modalities are tools that we use, to help reduce the pain. Ultrasound, not ultrasound for imaging, but ultrasound is more for can produce a heating response, especially deep in the body. That's shown to help with reduced pain associated with arthritis. Could help with bursitis as well too. TENS unit could help. There's some small studies that a TENS unit. It's basically this little pack, probably the size of your phone, that's attached to patches that you put on your body, and then it gives a little stimulation to that area. And how it works, it almost rewires so that your body, rather than sensing pain, senses that stimulation, that electrical stim that's happening from the TENS unit. Whole body vibration has some studies have shown positive results with that in regards to arthritis. And low level laser therapy has shown some minor benefits when it comes to knee arthritis. Shockwave therapy, although a pretty good tool to use for tendinopathies and calcific tendinopathies, kind of mixed as to whether or not it could help for arthritis, but it could help for tendon pains that you might have as a result of arthritis. And dry needling, that's also another avenue to help reduce muscle pain that could be a response or result of our arthritis. So, as a physical medicine, rehabilitation, and sports medicine provider, I do a variety of different injections. Usually, I like reserving these for patients that aren't getting better with exercises, maybe a course of oral medications, some modalities that we try. It's almost never my first go. This is usually for patients that aren't getting better. Um, Steroid injections, a lot of you might know, it's very commonly done. Steroid injections are another anti-inflammatory known as ketorolac. It could help reduce pain significantly. May depend, and this could be done for your any joint, for your hip, for your knee, for your shoulder. Epidural injections for your spine. It could be done in a variety of areas, and ultrasound helps improve the localization or help making sure we go to the right area. But we want to make sure, you want to be careful, because you don't want to do steroid injections too often. It's okay here and there, but too much corticosteroid, or cortisone or steroid use, can lead to additional wear and tear of the area it's being injected. Too much use of it can have what we call systemic effects, all over throughout the body. It can cause, for diabetics, it can elevate your blood sugar. It could cause water retention. So we want to make sure that we're picking and choosing, how we do it, when we do it, why we do it. For the knees, gel injections. A lot of you might have heard about gel injections. A friend might have gotten a gel injection before. Um, it's a very good option for patients with knee arthritis. It's only approved by insurance for knee arthritis currently. And the nice thing about it is there's not much downside to getting it. There's no deleterious or bad side effects with the gel injections, and it has shown to be able to show improvement in pain when it comes to mild to moderate arthritis. Not as good in severe arthritis, but I have found that sometimes I have patients with severe arthritis that it does help. And sometimes I've had the patient with a mild arthritis that it doesn't help. So it's a good option to try with not as many side effects that is covered by insurance. Um, you know, Both of these injections, they're both targeted at treating the pain. They're not necessarily reducing the arthritis, but they could help reduce the pain to help you to be able to get you exercise, function, do the things that you need to do and want to do. Platelet-rich plasma is a somewhat newer, it's not too new. It's been around for a little bit, but newer. Um, Injection. It's still considered experimental, so not covered by insurance. We actually concentrate the platelets, in your body. Ordinarily, when you get a cut or something that might be on your hand, your platelets are what come quickly to the scene of that cut that you might have, to help stop that bleed, but also help recruit some of the healing cells to help that area to regenerate. So what we try to do is we actually do a blood sample to help concentrate those platelets, yeah, and then inject it right into the site that you might have the pain. And it's not going to help reduce the arthritis, of course, but there are some studies that have shown a positive effect in helping reduce the pain, once again, without the adverse effect, of causing additional wear and tear on the body. So that's an option that might have some benefit when it comes to arthritis. It's good for tendons, and could be beneficial for arthritis as well too. Prolotherapy, stem cell therapy are also other injection options that are available, and that have shown some mixed benefits. I mean, more research is being looked into all three of these things as well too. And then sometimes it's hard, to actually target the joint itself, whether it be you have a pain and you had a cortisone injection and it's not get or another type of injection and it's severe enough that it's just not getting better, or such as with the spine, there's a smaller joint called the facet joint. It's hard to actually get a needle in there because it's such a small joint. So sometimes we actually do nerve blocks rather than targeting the joint that's causing you pain. We target the nerves that are around the joint that are causing you pain. Just like when you might have your tooth numbed for a dental procedure. We're actually kind of or numbing the knee or numbing the shoulder, or numbing the specific joint in the back that's causing you pain. So those are nerve blocks. So um, those are nerve blocks procedures, and they then go on to do ablations to give you longer standing relief. So it's not just a temporary, a short, like couple of hour block. It could be like a 6 month relief with the ablation. So common ones are ones for the facet. They're known as medial branch blocks, or genicular blocks for the knee. Now, when it comes to vitamins or supplements, there's some evidence in regards to some of them. Curcumin or turmeric has there are some studies that have shown evidence for its anti-inflammatory effect. So it's possible, especially mixed with pepper, that there could be some anti-inflammatory effect with it as well that could decrease pain. Glucosamine chondroitin, a lot of patients ask me about the benefit of using this. The studies are a little mixed when it comes to this. It hasn't shown a clear benefit when it comes to the larger joints, the knees, the hips. So not really a clear benefit when it comes to that, but there are studies that have shown that it could help with uh, arthritis at the base of your hand, actually. So it's possible that it could help without, much side effects that you need to worry about. Fish oil and omega-3, as well as ginger and antioxidants such as vitamin D, have also shown some anti-inflammatory effect, plus, some benefit when it comes to the pain associated with arthritis. Other avenues, yoga has been pretty good, and Tai Chi especially has shown to improve, arthritis and balance when it comes to the knees, when it comes to the ankles. Acupuncture has also had shown some relief, especially when it comes to chronic low back pain or muscle pain as a result of arthritis. The kind of biggest thing when it comes to any of this, going back to my original point, is the one I like to stress the most is exercise. Exercise, strengthening, maintaining your cardiac health is what I say would be the most important thing. That's the one thing that I would say, we have these options that are available for you. Where would you like to start? If it's going to be one thing, let it be the physical therapy and or exercises on your own that you're comfortable with. Everything else, the bracing, the medications, the injections, the modalities, are to help get you there and help diminish your pain so that you could exercise. In my point of view, it's just to get you there, decrease your pain, get you over that hump so you can do those exercises, so you could go back to, doing those activities. So one nice thing that we have available at the Valley, At Valley Health is we have the nice aquatherapy pool that's available. They have the pool that's there for specifically for aquatherapy for patients that might have a lot of pain in their knees and their hips or other areas or other reasons, gait imbalance, walking, and it's pretty nice. Also, as a part of the gym there, they do have different classes, weight management groups. They do offer yoga, Pilates, cycling classes, and the variety of therapy. Physical therapy locations that are available in Mawa, in Ridgewood in two locations, and newly available actually in Montville, just down the street from the library. So it's pretty nice facilities that are there. Now, ultimately, for some patients that are having persistent pain, despite all the things that we try, medications, therapies, injections, bracing, still having persistent pain that's limiting function or decreasing their the things that they need to do that want to do, right? That's when we then move on from all the non-surgical things that we are able to do to then our surgical partners. And then usually when it comes to arthritis, it entails having some kind of replacement, whether it be a knee replacement or a shoulder replacement or a hip replacement. They're usually replacing that joint, um, especially if they need to correct for some malalignment, that's there that needs to be like corrected. So we'll then refer for surgery, and sometimes they still need, physical therapy or some management of their pain or, muscle issues that could happen thereafter. But this is would be the next step, and you always want to find that sweet spot. Patients will ask me, well, should I do surgery? Should I not do surgery? And usually, the biggest thing that I'll kind of throw back at you is, well, you tell me if you need to do surgery. How bad is your pain? Like, are you able to do like what is the severity of your symptoms? Are you able to do the things you need to do and want to do, or do you find that it's still limiting you? You have arthritis in there, but are you able to live your life pain free without it affecting you? If that's a yes, then no, you don't need to necessarily do surgery. You want to do it when you're ready to do it, and what helps with your timeline as well too. So what are reasons to get evaluated sooner by a physician? You're doing things on your own, maybe exercising on your own in the beginning, but when is it more important to get evaluated by a physician sooner? So pain that's associated with like a fall or like a trauma or injury, those things you want to get evaluated sooner. Pain or that's associated with weakness or just painless weakness or numbness, those ones you want to get evaluated sooner. The multiple joint swelling, there could be some kind of inflammatory condition that's going on. We want to see those patients as well. When there's a fever that's associated with pain or like a swelling in your knee, or those ones we want to see sooner. Or difficulty walking because not necessarily because of pain, but like, you're unable to walk. Any history of cancer that you might have in yourself, or, treatments that you've had for it otherwise, and any abnormal weight loss. Another thing is if you're having pain in your back and all of a sudden you have what we call saddle anesthesia, that's numbness in the inner aspect of your thighs, and or difficulty with controlling your bowel movements or your urinary your urination, meaning you're wetting yourself or soiling yourself and you're not sure why. You didn't even recall that you did that. Those are definitely reasons to get more emergent evaluation. So prevention, what can I do to, prevent arthritis, or at least prevent symptomatic arthritis? General health and exercise is the most important thing. Keep that weight down, a good nutrition, avoiding pro-inflammatory things, smoking, it can be pro-inflammatory, excessive alcohol use, those kinds of things. Avoiding repetitive activities, those kinds of things, or at least modifying your activities to compensate for that, or building up your endurance to be able to meet that capacity. Once again, maintaining a healthy weight, not smoking. If you're in a position where you need to lift a lot, whether it be for work or just at home, you want to make sure that you're lifting correctly, not putting too much strain on your back, lifting, from your glutes, from your knees. And you want to make sure, good comfortable shoes and a good comfortable bed can go a long way, making sure that you're not wearing shoes just for you want to focus on, function over form, right? Maybe not just the looks of it, but also that you're comfortable in it. So that's usually the gist of things that I say when it comes to helping prevent at least symptomatic arthritis. So that's all that I have today. It's just a quick summary of some of the things that we do as physiatrists. Not the whole thing that we could do. There's a lot of other things, and this is specifically on the topic of arthritis. But as a physiatrist, a sports medicine physician, we typically treat any joint, muscle, tendon, or nerve of the body with a specific focus on function and getting you back into doing the things that you do need to do and want to do. As I said, my name is Samuel Jacob. Currently, my offices are located at Ridgewood in the Old Valley Hospital building, now known as the Legacy Campus, where the old hospital used to be, or in Wayne. But my partner's Dr. Jack Annunziato is also located in Ridgewood and seeing patients there. And Dr. Michael Chen is also there, and he's actually seeing patients in Ridgewood as well as in the new facility in Montvale as well too. So below is my information. Feel free to ask any question, whether it be now or later on down the line. I'm more than happy to answer any questions that you might have.
Thank you so much, Dr. Jacob. That was so interesting and comprehensive. Just a couple of questions. Somebody's asking about those TENS devices.
Mhm.
You've heard about those and wanted to know what you thought of them.
Yeah, I mean, let me just looking at some of the questions.
Yeah, you choose. Go ahead.
Oh yeah, and so the TENS device.
Mhm,
So when it comes to a TENS device, kind of how there is it could help with the pain. It's not necessarily removing the pain. What I like to compare it to is like the warmer on your car. You go into your car, you might have a back pain. You throw that car warmer on, and it feels
mhm,
great. So it's going to feel great where you have it. The pain might return afterwards, but it can be a great device to use for especially like temporary pains or just to kind of get you out of that rut. You go to the gym, you work out, you walked, you went on a trip, you came back, you're in a lot of pain. You want to just put on your back, your shoulder, your knee. The idea of how it works is it almost distracts your body from the pain. Um, your pain travels to your brain um, via local routes. It takes the local route and it gets to your brain, but let's call that the parking lot. The TENS unit sends this electrical signals, and those electrical signals go through a highway. So those signals go much faster than the local routes, and they get to your brain much quicker, and they fill up the parking lot essentially. So you're not necessarily feeling those slower pain signals. You're feeling that stimulation. And so that's essentially how it kind of works. And it could help, kind of, distract slash reduce that pain symptom that you're feeling by sending those other signals as well too. So it does has shown to help reduce pain. Might not be a permanent kind of fix, but for those moments that you might be sore and in pain, it can be pretty beneficial without having heavy kind of consequences. Always want to be careful. Obviously, if you have any cardiac issues, you want to make sure you don't put it here, of course, on your chest. Um,
Yeah.
Enzo is one such device that has shown benefit. There's no specific device, by the way, that I specifically recommend. I believe the Enzo is nice because it's actually wireless as opposed to having the wires. But that's kind of so some people will actually carry that around and just have the app on their phone and control the TENS unit. So that's a pretty nice feature to have. But there's no specific device that I recommend.
Mhm. Great. Are you familiar with tuning forks or any of those types of interventions? A little more.
Not evidence-wise with the specific, arthritis. It could help with the vibration component of it as well as for muscle issues. Um, you know, Not much downside with it and sometimes used, with by some therapists by Eastern medicine as well too to help with some of the musculoskeletal consequences of symptomatic arthritis pain.
Mhm.
So not harmful, but certainly okay to try as well too. Similar to that, cupping can also help. For patients that might have like you know um, a lot of muscle stiffness, a lot of muscle tightness. Cupping is actually another avenue as well too to help bring blood flow to those stiff muscles, those stiff areas. Could be pretty beneficial. That the dry needling we talked about as well too. So
Right.
sometimes not specifically treating the arthritis itself, but some of the referred pain from the arthritis.
Mhm. Are you familiar with any medications, that do not affect blood
Ah,
pressure?
That's a really good question. So your typical, maybe like Medrol dose pack or steroid injections, the injections can bump up the blood pressure a little bit, but just steroid pack or even like ibuprofen, Advil, Motrin, Aleve, those can increase blood pressure. So patients that have high blood pressure or blood pressure that's not controlled, we want to be wary. Those are nice medications, the Advil, Motrin, Aleve, because they're over the counter, they're there, they're helpful. But if you're on a blood thinner, you can't take it. If you have like heavy cardiac issues, you have to be careful with it. Or a patient with like kidney disease, or like ulcers, you have to be wary of those medications. And blood pressure as well too. Um, so those things can all, cause increases in blood pressure, and they're great medications, but you want to make sure that you're using it in the appropriate setting, and there's no reason why you can't take it. Um, there are other medications. Tylenol is nice in that it doesn't increase blood pressures. The nerve medications that I mentioned, they don't increase blood pressure. Sometimes, not often for arthritis, but sometimes we make use of muscle relaxers. That doesn't increase it. When it comes to THC creams, CBD creams, there's some benefit. When it comes to THC, you're more so not directly affecting the arthritis itself, but more so the pain receptors of arthritis. And truthfully, I don't do a lot of the THC aspect. No, I don't do any of the THC aspect kind of things or medical marijuana kind of things. Those but, you know, at least from the evidence, you always want to find that fine balance of the THC, which is that could be more of what is used for the recreational purposes, as opposed to the CBD, which can provide more of what we call analgesic kind of. That's why you could readily buy CBD, because that doesn't have any of those other worrisome kind of side effects as well too. And some patients say that it helps them. Um, Without bumping up the blood pressure, the CBD component of things. So
Right.
nothing against it, but might not specifically be targeting the pain.
Someone has a question about arthritis causing numbness versus pain. And are you familiar with that and different types of treatment for that?
So arthritis directly does not ever cause numbness directly. It is more indirectly. So that means there's decent enough arthritis that there's a nerve that's affected. Usually, when there's numbness involved, there's something that's going on with the nerve, because the nerve is what's sending the signal to your brain to sense things, to touch things. So it's more of a, okay, the arthritis is pushing on a nerve or compressing a nerve that could be causing numbness, tingling, burning. And how we typically try to chase that is we try to help relieve the compression that's on the nerve, whether it be with physical therapy and decompression exercises to help release the nerve, whether it be injections to help bathe that nerve with like steroids, or whether it be surgical type interventions to help release that nerve. I see that someone had also wrote about carpal tunnel itself. Carpal tunnel isn't necessarily, sorry, carpal tunnel is not as a result of arthritis. Carpal tunnel is basically, there's a nerve, if everyone can see me, that runs through your wrist called the median nerve. And that nerve is surrounded by a couple of other tendons that bend your fingers. And on top of that, there lies a sheet. And sometimes that sheet can get, or sorry, that area under the sheet can get very crowded. We see this most commonly with overuse. You know, you type a lot, you use your hands a lot, you write a lot, overuse, pregnancy, when there's swelling that's happening, thyroid issues that are happening, underlying inflammatory disorders that are happening. We usually see that because it's the nerve is getting compressed. It's not necessarily arthritis. I mean, the only chance that you'd probably see it with arthritis specifically, which is a disease of the bone, right? Not a nerve, is if there happens, and you don't see this commonly, but if there happens to be a lot of arthritis that's in your hand and that's causing a compression of the nerve, but not one that we would really see commonly, probably unless there was like a significant trauma or injury that had happened to the hand. And carpal tunnel itself is managed a lot of ways depending on its severity.